big privilege for me to be introducing Dr.Jothydev Kesavadev, and is a chairman of Jothydev Diabetes Research Center and Vice President, Geriatric Society of India, alumnus of Government Medical College Trivandrum, and author of several original publications. He's a pioneer in research publications on insulin pump telemedicine and cost-effective CGM and incretins. And most importantly, for people like us who are actually working abroad, we are in contact with his monthly internet diabetes newsletters since 7 years and hundreds of diabetes educational videos via YouTube, which has been most helpful, and more than 2,000 diabetes educational television programs. Without further delay, please, Dr. Jothydev Kesavadev.
Thank you, dear chairperson, my dear friend, Dr.Ali Siyan. And let me take this opportunity to welcome all of you once again to this fourth annual International JPEF Convention. The success of any such scientific program solely depends on our illustrious faculty and the highly interactive audience, and thanks so much. And respected senior physicians, my teachers, friends, colleagues, my topic is on cost of diabetes care, which is probably one of the themes of this year's event. At the end of my presentation, you should be able to answer to the following questions. Are we justified in using some of these expensive technologies and medications in diabetes? And if justified, when to use and when not to use, and which of all these technologies to be used, and how to customize these technologies to individual requirements. As clinicians, I believe that I should be starting my presentation with the biography of a patient, a 55-year-old type 1 patient. He himself is a very busy businessman, sufficiently affordable, diagnosed of type 1 diabetes 7 years back at the age of 48. And initially he was diagnosed to have type 2 diabetes and initiated on oral medications. And within a month he was hospitalized for diabetic ketoacidosis, and there he was switched over to a biphasic insulin twice daily. And in the last 1 year, he had more than 4 hospitalizations, either for a high sugar or for a low sugar. And ultimately, he and his household came to a conclusion that the treatment for this disease is not available in the country, and hence he has to go outside India. It's a very funny situation, but happens. Most of the times it happens. And he went outside India to a developed country, and there he was admitted and he was put on an insulin pump. And then, to his surprise and to the shock of the family, he was hospitalized within a week of his return to his hometown. And this time, it was a serious, severe hypoglycemia. He was found unconscious in the morning, and this guy was in the ICU for more than 5 days, and from that hospital, he was referred to our center. And it is quite justified for any human being, you and me, to be very frustrated, tired, and depressed after all these bitter experiences. And at the time of admission, his A1C was 10.8%. And we decided to perform the 14-day ambulatory profile with the new Libre sensor, which I am sure many of you are already familiar with. And this is a classical appearance of the 14-day ambulatory glucose profile, which is the classical picture in type 1 diabetes with huge glucose variability, both interday and intraday. And the question, I can expect a question from you. Are these newer gadgets reliable? Are they accurate? Because this is the first sensor in the history of diabetes care which doesn't require the glucometer pricks, which doesn't require calibration, whereas all these sensors will require calibrations at least once or twice per day. This is a recent publication in the Diabetes Technology and Therapeutics Journal, both in type 1 and type 2 diabetes. And this is a Clark error grid zone and the Park consensus error grid zone comparing the sensor glucose values with simultaneously conducted capillary glucose values in the same reader. In the Libre reader, there is a glucometer incorporated with it, that is a precision glucometer. And this is again very exciting. Almost 99% of the time, the sensor values have correlated. And these are the sensor error grid zone A and B put together. So the clinical accuracy of the sensors are assessed with help of error grid zone. And what about the quantitative accuracy? The quantitative accuracy of these sensors are assessed with the help of MARD, mean absolute relative difference. Lower the mean amplitude, mean absolute relative difference, higher is the accuracy of these sensors. So this is the sensor readings or MARD across the 14 days of sensing the glucose from day 1 onwards. On an average, the MARD is 10.5%. However, this is a word of caution, except the first 24 hours. And this happens with almost all the glucose sensors. When you introduce a needle, there is a trauma and there is an inflammatory change, and it changes the interstitial glucose environment. And hence, during the first day of sensing, the sensor glucoses will be inaccurate. And hence, if you are performing the continuous glucose monitoring for fine-tuning of blood glucose values, then you probably need to eliminate the initial 24 hours. So we explained the ambulatory glucose profile, the continuous glucose monitoring over the 14 days, educated the necessity of switching to a different device, which is different from the insulin pump currently deployed from another country. And this is very helpful. The ambulatory glucose profile download. If you carefully look at these data, the insights, there are 5 different zones, and 3 of these zones you have the red light signals. That signifies, especially during the early morning hours, this is 4 a.m. and this is 6 a.m. in the morning, serious episodes, and it predicts a hypoglycemia. But if you look at the report which is generated from the same software, it says it makes it difficult to achieve the target glucose level without increasing the likelihood of a low glucose. I repeat, it is almost impossible for this patient to reach a glucose goal without the occurrence of a hypoglycemia. So it's already documented by the device. And now you need a technology which will get rid of hypoglycemia. And that is the predictive low glucose suspend mechanism, and that predicts the onset of hypo. This is a very simple study. I have put the threshold of hypo at 60 milligrams per deciliter. And over here, the red colored ones are the YSI, or the standard reference of glucose values, the yellow spring instrument. And in blue, you have the controller or the sensor glucose being generated. And when the glucoses are dropping, it is gradually coming down, but before it reaches a threshold of 60 milligram, 30 minutes before the occurrence of an actual hypo, it suspends the delivery of insulin. And that is a predictive suspend mechanism. So the hypos are entirely eliminated by this mechanism. In green, you have the basal insulin delivery, which is suspended, and now it is automatically resuspended when the glucose values are normal. So we have our first patient on 640G in the September of 2015, and this first generation artificial pancreas is the one which has got an incorporated algorithm in addition to sensing the glucose to predict and to suspend the delivery of insulin. For those of you not familiar with the 640G download, this is how it looks like. The hyperglycemias are persisting. This is 1 week after the deployment of the new artificial pancreas or first generation 640G. If you look at the acceptable zone, which is green over here, there are no episodes of hypo. The hypos are completely eliminated. And let me dissect and go to a single day. This is 14th of July, the same patient, 1 week after the deployment. Focus on this area. This is 1 a.m. in the morning. This is 2 a.m. in the morning. There is a low trend. But before the occurrence of an actual hypoglycemia, the insulin delivery has automatically suspended. This red dotted lines over here indicates suspend before low. That is a predictive suspend. But there are certain areas where there is a green bar, and this is manual suspend. And this is morning around 8 a.m. when the patient has manually suspended the pump to take a shower. So now, the conclusion or the question, are we not justified? Am I not justified for a patient who is depressed, lost in his business, frustrated, lost his quality of life, to offer the best and the latest to bring back his quality of life? And that is a solution for eligible patients who need to be put on such devices. These are the broad indications for the use of insulin pump. We have published in a global journal. This is a consensus from the group in India. And again, it is published recently in JPEF. And from insulin pump, let me move on to the simplest technology in diabetes, which we have been using for several decades now, the glucometer. And this is a model which is created based upon a study from Compatia in 2013 on the 10-year financial risk for somebody who doesn't use SMPG or self-monitoring of blood glucose. And the same model is compared against somebody or the same subject who uses a glucometer at least once daily, different times of the day. And this is a risk-benefit ratio. You save a lot of money at the single risk of spending this much more for glucose monitoring. And this is to share our personal experiences using telemedicine in diabetes care. We have published on the cost effectiveness. We have data on achieving even very low targets without hypoglycemia. And recently, we published a review. This is in IJEM. And here we have proven the sustainability for any technology in medicine or in diabetes to be acceptable globally. You need to prove its sustainability or durability over several years. And this is a publication where we have proven the sustainability and feasibility of using this technology for over 15 years. And this is an interesting publication. One medical student from Yale University of Medicine in the US came on a sabbatical with us and spent a couple of months. And at that time, we were running one more center. In our main center, we had telemedicine and comprehensive diabetes care. And the other center, we were offering the conventional diabetes care. And that was a charity center. And this lady, Rebecca Vitali, did a study comparing the two centers, the two levels of care in diabetes. Of course, there are 3 levels of care in diabetes as published by the International Diabetes Federation. And she came up with the conclusion in this study that there is a huge difference between the two centers in terms of outcomes. Not only with A1C, but also with cardiovascular risk parameters. There is a similar study recently from 4 centers in the United Kingdom, published a week ago, comparing 2 such modalities of therapy in diabetes. Telemedicine and comprehensive care is extremely cost-effective in the long run. This is a follow-up data of a subject on 17 years follow-up in our diabetes telemanagement system. And currently with the duration of diabetes of 25 years, consistently on an A1C below 7% and no complications till date. And this is the average cost of somebody with 25 years of diabetes with no complications. So we were listening to the oration by our great speaker, Dr. Jothydev sir, on diabetic nephropathy. This is a model where the patient hasn't developed any complications. And I have included the cost of insulin, I have included the cost of gliptins, the blood pressure medications, the strips, needles, lancets, and this is the average monthly cost of around 4,000 to 5,000 rupees. And this is slightly higher than the usual cost of treating diabetes in a conventional fashion. So let me go to the cost of sensing with the new technology, considering the average cost of a strip at 27 rupees and the LibrePro sensor yielding 96 readings per day, which translates to 1,344 readings in 14 days. And you save almost 35,000 rupees, and that too without the pain of monitoring, and that too with the wealth of data which is acquired with the help of algorithms generated from glucose values and with the inbuilt algorithm. And just compare the cost against the procedures. The cost of hemodialysis, the cost of peritoneal dialysis, the cost of a renal transplant or a coronary bypass, and the cost of amputations. I am trying to save the time in my presentation since we were 15 minutes behind the schedule. And most of the numbers and most of the technologies that I have briefly discussed today, you may not believe, because some of them are unbelievable. But our patients have already started experiencing the excitement of using all these newer technologies, which has got probably a higher cost in the beginning, and over the years, the cost gradually and steadily declines, and you need to believe it. And thank you so much for your patient hearing, and extremely thankful to all of you being present over here, and a very special thanks to our beloved Guru, Dr. Sheshaya sir, for being here from Chennai and giving the Dr. V.C. Mathurai Memorial Oration. Thank you so much, my dear friends.
Thank you, Dr. Jothydev, for the informative session. Is there any questions or clarifications from the audience?
What is the cost of 640G and what is the HbA1c value on 640G patients?
640G, the cost is 6 lakhs per device, and the monthly cost is similar to that of other insulin pumps. But the upfront cost is 6 lakhs. Because I have cited an example of an individual who lost more than 2 crores in his business because of hospitalizations twice a month for the last more than 2 years. So there are a lot of such patients in our country who can be put on such devices. And the 640G is primarily aimed for treating type 1 diabetes and for long-standing and late type 2 diabetes when the glucoses are really brittle. Because this is the first device which will take care of hypoglycemia. So the next device is 670G. And I haven't shown, but I will be showing it in the next room, the Bionic Pancreas. And the Bionic Pancreas is the islet, which will have 2 independent insulin pumping devices, one with insulin and the other with the glucagon. So there are 5 generations to come. And this is the first generation which integrates an algorithm. And that is why it's called artificial pancreas. HbA1c for all these patients, it will be around 7 already. So you can decide, because A1c, when it is very high, now the rule in diabetes is you have to individualize the A1c values for patients. So when a patient is using a device will take care of hypoglycemia, you can aim at an A1c of around 6.5, because there is no apprehension of them dying during the night. So it is individualization of A1c based on 6 to 7 parameters, whether it need to be an aggressive management of diabetes or it need to be a relaxed management of diabetes. You have that ADA recommendation on how to decide on your A1C target in individual patients. So this is type 1. So in type 1, you need to be very careful. Unless and until you are using these newer devices, will eliminate hypoglycemia. So this eliminates hypo. The 670G will take care of hyperglycemia. So it is step-by-step approach to totally artificial pancreas.
While using 640G, you said the suspension of basal insulin, once there is a decrease in 1 a.m. or 2 a.m. Blood sugar level. What happens for the bolus insulin? It can sense whether it is postprandial hypoglycemia or the early morning hypoglycemia. It can suspend basal or bolus accordingly.
Yes, absolutely. During the, we are using only the rapid-acting analog insulins in insulin pumps. And the rapid-acting analog insulins, the preferred one is Aspart or Novorapid, which will have a mean duration of up to 4 to 5 hours. So hence, during the nocturnal sleeping hours, there is no bolus insulin which is left. But for your precise question on suspend, it is suspension of the pump, both the bolus and the basal stops. The auto suspend is for both, but bolus is not there during the night. Once they bolus at 9 o'clock or 10 o'clock, nothing is left at around 2 a.m. or 3 a.m. The graph is the basal delivery suspension. The bolus is manual, but there are hybrid insulin pumps where during the nocturnal hours it is fully automatic. That is how the hybrid is defined. And during the daytime, you announce the meals. Meal announcement means you are using a manual bolus. And there again, auto suspend is possible.
I think that's all we have time for. Always thank you, Dr. Jothydev, for keeping us up to date on the latest technologies.